I want to set up this last plenary a little bit, and then I'll hand it over to the folks up here on the stage. So as many of you know, this is the first year that we've... what are they doing behind me?
It's cold.
This is the first year that we've brought together the PBRN conference and the Practice Facilitation conference. And the idea was that there were lots of overlaps between people, lots of overlaps between interests. And as we started talking across the groups, we thought it would be really nice to do something at the end of our conference to sort of begin to knit the two together and weave together some threads of discussion and that sort of thing. So we tasked a group of folks, some from our planning committee, some from their planning committee, to come up with a closing plenary for us. And here we are. So without further ado, I'm going to hand it off to Melinda, who's going to take it away.
Yeah. So thank you so much. We're really excited to be here today. And initially we thought about having a panel, but we've decided we'll actually have a fireside chat. And so what we'd love to do is actually to invite you guys to come closer. So I'm Melinda Davis. I'm an associate professor at Oregon Health and Sciences University. And I've worked with the Oregon Rural Practice-Based Research Network actually for about 12 years. And so I started as a practice facilitator working out in rural Northeast Oregon. So raise your hand if you've been to Oregon. Okay. Keep your hand up if when you came to Oregon, you actually went to the east side of the state. Okay. So Oregon is a very big state, right? It takes about 9 hours to drive east to west and probably about 8 or 9 north to south. Basically, so the eastern side of the state is much closer to farmland compared to Portland, which is kind of the temperate rainforest. So we have a real diverse population there. And I think what's relevant in telling you that is that when I first joined ORPRN, I was invited 6 months after I started to come to this practice-based research network meeting and to serve on a panel about practice facilitation. And if you remember when you're starting a new job, that's about the time you're starting to understand the acronyms, but you still don't know them all. But it was a wonderful experience, and actually in that meeting I had the opportunity to meet Jolt, who's around the campfire with us today. And the reason at that time we said, well, wouldn't it be wonderful to create a space where folks doing practice facilitation could actually come together to talk about their work and to really build that community. And so luckily 3 years ago, with the support of Bob McNellis and others at ARC, we received a conference grant. Thanks, Bob. We have marshmallows for you later. But we received a conference grant, and so we've had this opportunity to host this kind of brainchild that Jolt had for the last 3 years. And so we'll be going into the 3rd International Conference on Practice Facilitation actually starting tomorrow. And so what we wanted to do is to create a space to kind of have an informal dialogue about what is facilitation. And if you look at your program, you can see that there were 3 kind of goals there. And I'd say there's 3 plus 1. So we really want to highlight what do facilitators do. We want to talk about how the profession is evolving and give you some examples. We'll talk about opportunities, or hopefully have a dialogue for opportunities about how you as either a clinician or researcher or a facilitator yourself might engage with practice facilitation. And then throughout, we'll try to draw some parallels between this kind of provider-patient relationship and facilitator-clinic relationship, because there are a lot of parallels in terms of how we think about goal-directed care versus disease-focused care, okay? So what I want to do, we've already got you to come closer, but one of the things we do often at the ICPF, the International Conference on Practice Facilitation, is we build in opportunities for interaction. So sometimes when you come to these meetings, right, you see other people talking, they look like they know each other, you wonder where your friends are, if you'll always be alone. And so what we try to do is to build in opportunities for informal networking. So what we want you to do is turn to the person next to you, tell them what your name is, what drew you to the PBRN meeting, And what the heck do you hope this panel will help you understand today? So let's take maybe a minute or two, find a person next to you, and make a friend, okay? All right. So we have Stephen, AKA Phil Donahue.
Hello.
Work in the audience. And what we'd like to ask is, would a few of you be willing to share what do you hope to learn from this fireside chat today?
Marie from University of Montreal,
Thank
PBRN. And I was sharing with my new friends that one of the things I'd like to learn about is the difference between what we call QI agents, quality improvement agents that are embedded in our academic clinics, and our research facilitator that's embedded in our PBRN. That was the first thing. So if you could address that, I'd be really happy. And the second one, what was my second one? Now, oh yes, the parallel between the relationship stuff you talked about, doctor-patient relationship, and was it practice facilitation and the practices relationship? So I'm curious about that.
We will definitely highlight the second one. I think the first one, we would invite you to come to the ICPF and to help us with some research, because I think that's an exemplary question. We'll, I think, reflect on that some and how we work with those different roles, but I think that's a real opportunity. So, yeah, beautiful. Okay. Anyone else?
Shandy, I'm from Canada, from Quebec. We're a network of 4 PBRNs, including
Canada is winning, just so you know, America.
So we're watching what's happening in the States with a lot of interest. Have been learning from you for several years. But I think there's some real challenges right now in terms of funding and particularly facilitation roles. We're sort of on an upswing in Canada with a lot of interest in this network structure and this role. So just your sense of the future challenges and opportunities, because I think you're a bit ahead of us and we can hopefully avoid some.
Thank you. Okay, we have time for one more, so raise your hand quickly to be that individual.
Well, I am from Atrium Health in Charlotte, North Carolina, and we are a PBRN. I think we were really interested in learning more about how the practice facilitation works in the community setting. So I'm really excited to learn more about that in the ICPF conference that's starting tomorrow.
Thank you. Well, those are all brilliant segues. So I haven't introduced you to my colleagues up here around the fire, in part because one of the kind of key principles, I think, with practice facilitation is to start with you, right? And to really understand where you're coming from. And so what I want to do now, because people have had the opportunity to hear a little bit more about what brought them, is to introduce you to the panel. And this is a panel of facilitators, program leads, researchers who have over 50 years of experience, both working in facilitation as well as with practice transformation. And so I'm just going to start with a pretty easy question. If each of you could tell me a little bit about your organization and your role, and maybe give us a little soundbite of what a normal day looks like for you. Let's start with you, Linda.
All right. Well, thank you, Melinda and Jolt, for having me be part of this panel. My name is Linda Edelman, and I am the co-director for a practice-based research network called the High Plains Research Network. I am based out of the University of Colorado and the Department of Family Medicine there. So my office, and where I do spend most of my time, is in Denver. But the High Plains Research Network works with 16 rural and frontier counties in the eastern part of Colorado. So I'm going to pause for a second and ask here who in the room has actually stepped foot in eastern Colorado. No way! That's awesome. Usually you're just flying over it on your way into Denver. But so the network has been around for about 20 years. And as a PBRN, obviously, we've done research projects on a whole host of different topics using a whole lot of different research methods. An important feature of our network is that we actually have local staff. So we have 2 research assistants / community liaisons / regional health connectors / practice facilitators. You can give them any of those names, who actually are in the region, in the communities, and in the practices. That's what they do, and they live there, they're from there, they know the region, and they know the community. An average day, that's a little tricky. An average day is spent on the phone for me, communicating with my staff. A lot of feedback. We try to bridge that distance in meetings, of course. Working on different aspects of grant projects. That's a very typical day. I do spend time in Eastern Colorado myself, but as I said, the staff is really local staff is an essential component of our network.
Thanks. I'll also add in if you want to share anything about a typical day and an atypical day, if that's helpful, if you want to highlight nuances in what you do.
Yeah. I will, because there's an important piece of our network that I didn't mention that I think will factor into this conversation is the work that we do both in the practice setting but also in the community setting. So we also have a very active community advisory council, which is a very grassroots level group. So an atypical day for me would be having an all-day meeting with that group. We meet quarterly, but they are essential to the work that we do and making sure that what's happening in the community and practices are very relevant. And I think that'll come up more in this conversation around facilitation.
Yeah, so I'm Stephen Brantley. I am a practice facilitator with the Oregon Rural Practice-Based Research Network at Oregon Health and Science University, which is quite a mouthful, but I work with Melinda. So I am, like our friends in Colorado, we have a regional model where I live in Southern Oregon and work primarily with practices in the southern part of the state. And like our colleagues in Colorado, we struggle with titles. So I am a research associate / practice facilitator. We've thrown around lots of other ways to classify the work that we do because it's tough. And you know, I think depending on who we're interfacing with, we might use a different title or a different name for the work that we do to make it more or less appealing to different groups of people. But yeah, that's me. I'd say a typical day. There isn't a typical day, but what I will say is sort of maybe some of the things that are different for me than your typical day. Because I'm remote, I do spend quite a bit of time trying to hunt down colleagues that would be easier found, you know, by saying, you know, dropping by their desk and asking if they wanted to go get coffee or things like that. That's sometimes takes more time than it would if I were in Portland with the rest of my team. But I spend the majority of my time now, the last couple of years, interfacing with practices, whether it's in person. There's quite a few groups within 10 or 15 miles of where I live, and so I'm able to, you know, if they call me or email me with a question or a problem, I'm able to drop by in person kind of immediately if I'm available. Otherwise, there's ones that are further away that I have to do a little more scheduling to get to, but lots of phone contact, lots of web conferences with practices and with other colleagues, so lots of time communicating and trying to coordinate the work that we do.
Maybe just to highlight an atypical day for Stephen is one of the stories we like to use is that Stephen had been courting a practice for a project for quite a while. And they called him around Christmas time and said, actually, the one time we can meet with you is on Christmas Eve. And so Stephen's an overachiever, and so he made that meeting, and that has been, I think, one of the tight-knit practices in his region ever since.
It was well worth it. They turned out to be a very good ally for that project and lots moving forward. So it was a good use of time.
Stephen also works with Colin, as do I, and I think there's a question you should ask yourself about who's your work best friend. I think there's some research about kind of longevity and productivity. And one of the things I've noticed is that even though Stephen is remote, and as Colin will tell you, he's located in the main office, they have a very strong friendship, which I think is a testament to part of how effective they can be. So.
Thanks, Melinda. Yeah, my name's Colin Conway. I'm basically Stephen, but based in Portland. So I'm a research associate practice facilitator. I'm based in Portland, but I have an amorphous region. I kind of go where projects bring me across the state. So currently, I'm spending a lot of my time in Central Oregon. I'd say a typical day for me right now is driving around the high deserts of Central Oregon, helping work with clinics on screening for social determinants of health, which has been a lot of work and a lot of fun, I think, at the same time. So I think Stephen captured who we are and where we're coming from, and that's a typical day for me at the moment.
Go ahead.
You see that I don't have any cover, so I'm the plus one. In a way, and my role is accordingly quite different. I'm Zsolt Nagykádi from the University of Oklahoma Health Sciences Center, Department of Family Medicine. Our network, one of our networks, OKPRN, was started in 1994, and it employed its first facilitator in 1999. So we have years to go back and reflect upon. I actually started out as a practice facilitator in our department in 2001, and then I became faculty and head of the research division, as well as directing the practice-based research networks research activities. But looking back on those years, it really gave me a tremendous foundation, respect, and I think a good understanding of what facilitators do. From my perspective as faculty work with practice facilitators, I recommend the same kind of experience, not necessarily that they would go out and facilitate themselves if they can't, but to learn more about practice facilitation. So when they work with facilitators, they know their limits, their capabilities, and how they are best utilized. So a typical day in our current system, actually there's Crystal Turner there, who is one of our practice facilitator coordinators. We have about 10 practice facilitators and sort of helping them, directing them, practice facilitator coordinators. That's an evolution of the system of facilitating when you have more of them. So in a typical day for me in that regard is to help especially our coordinators, co-manage projects, look at various aspects of facilitation, and sort of with the understanding of practice facilitation, help them be a resource to our practice facilitators. That an atypical day for me would be the opposite, what it used to be, that I spend my entire day out in a practice working with them. That doesn't happen as frequently these days, but I am happy to do that, and it's always a great experience to do.
Thanks. So we've introduced the panel, and next we're going to talk a little bit about what is facilitation. But you all just made a friend, and so you can remember their name. We're going to ask you to turn to that neighbor and just talk for a little bit. What does practice facilitation mean to you? So what I would love to do is let's have one or two groups just share a little soundbite. What does practice facilitation mean to you?
Hi, I'm Mary. I'm from Colorado, and my friends here are both from Haiti, which is so cool. So I'm learning a lot from them. But we were talking about how practice facilitators don't necessarily need to have a medical background or be a medical educator or anything initially, but need to have the passion and the ability to connect the dots. As well as I was hearing that social workers and psychologists or people with that background are often who these ladies go to in Haiti. And then we got caught off by needing to say jelly time, so sorry.
And are you guys facilitators? Is that what she said? No, physicians. Physicians, okay, great. But you have some experience working with facilitators. Awesome, cool. Does anybody else want to join in? Yeah, right there. Thanks, Greg.
And I'm Greg Eberhardt. I'm a general pediatrician and the community coordinator for our grassroots network, the Southwest Ohio Ambulatory Research Network. You said in a soundbite, I would say it's selling the value. That for clinicians, it's why should I do this? What's the value in it for me? Apart from the research part, how does this help me see my patients better, show them better value, selling the value.
So that's brilliant. So what I want to do is ask the panel here to talk just a little bit about practice facilitation. So I was going to call on you, Taryn, because I saw your partners behind you mouth to each other, I don't know, right? And I love that you joined right in because you do have some experience both with research and facilitation. But what I want to do is ask the audience, and I'm going to start with Zsolt, because if you're interested, Zsolt has written some of the early seminal work on what is practice facilitation that I think really highlights some of like the core roots of facilitation being about relationship across time and not necessarily just specific targeted research intervention, but actually meeting practices where they're at, helping them with quality improvement initiatives, and having that kind of longitudinal relationship, much like providers have with the practice. So Zsolt, do you mind, for those who maybe mouthed, I don't know, can you tell us what is facilitation?
Sure. I'm not sure I can tell you, but together we can construct what facilitation might be. So yes, there's some literature out there, and we can give you some pointers where to go. But early on, I think this dual role of practice facilitators that includes both the support of quality improvement, practice improvement, and research pops up in the early literature. The other important point that Melinda mentioned is the longitudinal relationships, that it spans over individual projects and it creates the human capital, the relationship capital behind all those improvement initiatives and all those things that a practice will need to go through or will want to go through with the help of the facilitator. So it's not like a research assistant who goes in, collects data, leaves the practice, and then that's it. So this is a kind of early definition of practice facilitation, these traits. Over the years, I think we have been able to add a few other things to that. So I would suggest that a practice facilitator or practice facilitators are trained healthcare professionals who develop personal relationships with a group of practices over an extended period of time. They help practices improve the quality of care using evidence-based quality improvement methods. They also help the practices participate in research. This is not a must, but it often happens. And help create and sustain a participatory learning community around the practice, going beyond just the individual practice, which a lot of QI projects do, and create a learning community. And thus, it dovetails with PBRN work wonderfully, because PBRNs, I think, supposed to be learning communities. Just very briefly on the background, we stole this idea from the UK. Early on, there was a GP called Dr. Arnold Elliott, who was sitting by the fireside in the waiting room, literally, watching the practices work. And he was a retired older physician with lots of life experience. Then he looked at the floor plan, the workflow, and after the observation, provided some advice and help for the practice and worked with the practice in terms of how to improve what they do. So, first principle, listening and observation. That's how patient care starts. That's how practice care / facilitation starts. Very important learning. Then it was later expanded. Today, as I am aware, there are thousands of practice facilitator agents in the UK working, funded by the National Health Service. Wish we had a National Health Service that could fund this kind of work. Characteristics. So these are what we heard as early as 1994. Facilitator is an agent of change, a coordinator, a cross-pollinator of good ideas. Again, this horizontal relationship idea. Resource provider, information giver, trainer, a little bit, sometimes a researcher or research facilitator, an advisor, mentor. So that's quite a task that facilitators have. In terms of top skills, what literature already identified and we among ourselves, excellent interpersonal and communication skills. It always rises to the top. Highly organized, systematic work, being able to be organized, attention to detail, being an insider-outsider, moving, not being as an employee, but at the same time becomes an honorary member of the practice. We had a functional definition, can come through the back door. We had to modify that after HIPAA. Team worker, quick learner, effective user of health information technology, flexibility, mobility. And just a few things, what are they trained? What have been they trained for? Among many others that you would expect in research. Rapid cycle QI, the audit and feedback cycle, benchmarking, group facilitation skills, practice visits, how to conduct a visit, how to build teams, team building, health information technology, guideline-related work, a whole host of electronic practice record and patient management record work and background. Of course, a lot of project-specific training. More recently, interesting areas like complex adaptive systems theory and its applications, and then patient and community-oriented research. I think the goals of facilitation include what the triple aim, or rather the quadruple aim, includes: improving the quality of primary care, improving the financial viability and joy in practice in primary care, improving the experience of primary care both for the practice and for the patient. But overall, I think a practice facilitator is a capacity builder. If someone who is able to build resiliency and capacity through the interaction, that stays in the practice. We are not supposed to do the practice's work. We need to teach them how to fish, build the capacity so that they can do that themselves. So I also liken facilitators to an enzyme. It helps through the substrate, the energy barrier, the initial barrier. The only difference is that the enzymes move on and go to other substrates. Here we teach the practice and help the practice do this, what they have done with our help as we go along. Let me stop here and then leave plenty of room for others.
And I think what I would ask the other facilitators here to do is, Jolt provided a really high-level summary and some of the bullets, right? And I'm hoping that each of you can maybe illustrate, because one of the things that some people may still be thinking is that seems like a lot, right? And there's a lot of parallels between, I think, the generalist primary care provider and the facilitator. And so I'm hoping maybe you can provide illustrative examples to get inside that black box and help us understand, what do you do as a facilitator, and how are you maybe balancing these priorities, making the value proposition to your providers as you're weighing the different projects you're working on?
Yeah, and I think I may give a more applied example a little later. A more general one, I think, related to Dr. Mold's talk. I'm not sure if he's here anymore, but the person-centered care. The relationship piece, I think the first things we tend to do as facilitators is get to know the clinic and listen, find out what's important, what the context is, and learn about the clinic as a way you might learn about a patient. And then I think one thing, if I do nothing else as a facilitator, I create space for a clinic to stop and reflect. I think we don't do that a ton as individuals or clinics or societies as much as we could. Think about where we are, why we're doing things the way we are, how we might do things differently. And so as we start investigating different processes, say it's a workflow around hypertension, well, how are we doing it today? Why are we doing it that way? Could we consider doing it differently? And then setting goals around how we might do it differently to get to that goal. And getting back to the patient analogy, I think sometimes we'll use a metric as a goal and we'll say, let's improve our hypertension, our blood pressure metric from 65 to 70 in the next 6 months or something. And I will say that while that's a great guiding framework, even if we don't, I've worked with plenty of practices that did not get to the patient outcome improvement, but in using that as a guiding goal, the pursuit towards that goal, we accomplished a lot of important progress in the capacity piece. And sometimes down the line, you'll see those metrics actually move once that foundation and some of the capacity is built. So finding what's meaningful, working towards goals, and creating space to think about how things might be differently has been an approach I take with, I'd say, virtually all of the clinics I work with.
Yes to that. I think all of that, I would say that for me, it really boils down to, as a facilitator, my main responsibility is to get to know the practice, become a trusted colleague that they are willing to go to when they have questions, that they are willing to partner with. They're willing to use some of their capital, whether it's time or money or access to their patients, to help us when we have a research need, but they're also willing to let us help them and let us provide support for what's important to them. So I think everything that's just been said, but for me, the relationship piece is the most critical, and that's how, getting back to the question that somebody up here asked at the beginning, what's different between a facilitator and a QI specialist or a consultant or a research specialist. I think the big difference that stands out for me is that we are much more interested in the needs of the practice, the needs of the people that we're facilitating, rather than putting ourselves first and our priorities first.
And I'm sure at another fire we could tell a lot more about the challenges of balancing those multiple priorities. I'm going to set Linda up a little bit. Catherine asked some about how facilitators work in community, and I just want to make sure you touch on that, because that's one of the ways that the role of the facilitator has really evolved over time.
Well, first, just a couple of words that come to mind when I think of practice facilitation, and when I speak with our team, words like coach and cheerleader. They're both there to support and promote change, but also to help the practice recognize what they're doing. I think oftentimes practices are making some changes and just it's maybe so ingrained in what they're doing that they don't realize it. And so being that cheerleader to say you're doing this is a very important piece of this work, and just being that consistent presence. My colleague Kristen Suter, who will be joining us tomorrow for the facilitation conference, jokingly says sometimes, I think half of my job is to show up, to be the person that forces the practice to come together and actually talk about what they need to do. Kristen has a unique role with the work that we do. So in Eastern Colorado, a lot of our work is based in the practice, but we also do a lot of community level work. And for those of you who work in rural communities, I think you can appreciate the importance of taking what's happening in the practice out of the walls of the clinic and engaging the community, the broader community, a little bit more in the work that we do. Sometimes with our Community Advisory Council, which I mentioned earlier, they will say, we have this project that's happening in the practice, or even if it's just making communities more aware of some of the specific transformation initiatives that are going on. How do we make more folks in the community aware of this? And so as a practice facilitator who is from the region, so knowing the community, has been there over time, has those relationships, she's able to help us really make sure that what we are proposing to do at the community level and in the practices are going to make sense. She has her feet planted in both environments. And I think that's a huge piece of the work that she does, and making sure that the work is relevant and feasible, and that the messages that we're creating and the work that we're doing is consistent. She's also able to help identify who else needs to be at the table to do this work effectively. So you have a practice team, but is there public health that needs to be there? Is there a local behavioral health care provider? Is there a church pastor? Who else needs to be at the table to make this effective and really stick? So those are some initial thoughts on that.
Yeah, I just want to maybe draw two parallels. I think in the literature there's the term boundary spanner. And so this is a person who bridges environments. Dr. Epling in his talk yesterday talked about Thinking Fast and Slow, that book, and it talks about type 1 and type 2 thinking. And I think facilitators play a really critical role of moving from the evidence that we generate in academic institutions or we put in toolkits about how you should do care, and they help translate that into the busy, almost like automatic response, dynamic environment that's happening in a setting. So they're really helping translate kind of that knowledge and figuring out how do we help move that into action, which is very much what PBRNs are also charged to do. Colin mentioned that he wasn't going to give a specific example, but I'm wondering if we could actually ask for a more illustrative example from someone up here that would highlight some of the dynamics that you're working with as a facilitator, something that could be used as an illustrative example. I think facilitation's hard because you're talking about it theoretically, right? And it's very nuanced and dynamic in terms of what's happening in real time. There's actually, I think, and it's not interesting, but there's a lot of parallels to evidence-based medicine in terms of facilitation and how we think about what are the core elements and what are best practices. And so there are partners who are doing rigorous research to look at what are facilitators doing during the maybe recruitment stage, or what people might say the adoption or pre-implementation stage. What are facilitators doing during implementation, and what are they doing during the sustainability phase? But I'm hoping, would someone be willing to give an example?
Well, since Colin won't. No, he will. I'll share an example of one of the practices I've worked with that was complicated. We didn't accomplish the goals we set out to, but it was still extraordinarily successful. And I think this is kind of illustrative of what facilitation is at its core. So this is a practice. It's 2 small rural practices that share an office and share some staff. And that at first seemed like a really good thing because they were working well together, everything seemed like it was pretty cohesive, and then I actually met them and realized that was not at all the case. There was actually a lot of animosity between the 2 different groups. And we had one provider, this was a hypertension control project, and we had one provider that basically said, I don't get quality improvement, I don't know why we need to do this seems stupid. However, my wife and clinic manager says that we are going to lose a ton of money this year, so I think we need to probably talk to you about this. So that's how we started. And then this was a 15-month project, and over the course of that time, to start with, the providers' voices were very loud, and everybody else was very afraid to speak up. That was one of the first things I worked on, was making room for the MAs, the front desk, the x-ray tech, the people in the back office, to be able to share their opinion, to share their voice, and to be heard. That was another challenge, is not just having them talk, but actually having the providers and the managers hear that and implement change. After that, we were doing some surveys for the project, and I took the surveys, collected them, and went on my way. And while I was driving home from collecting these surveys, I got a call from 2 separate groups, one from each of the practices, that didn't know the other had called me, saying, please destroy our surveys, we don't want the other site to see what we said. They both did that within the 3-hour period of me driving home. And I mean, so it was chaos. There was a lot of really bad relationships there. Over the course of that project, and then the last couple of years, I've continued to work with them on several other projects. It's not by any means perfect, but we worked through a lot of that. We worked through a lot of those problems. They have a much more cohesive model. They're talking, they meet once a month now as a whole team. They close the whole clinic down. Both groups sit down together, all 20 or so of them, and they talk about where things are at. They talk about their metrics. They talk about quality of life. Now the clinic manager and the providers are no longer the ones that are in charge of their quality improvement efforts. It's the MAs that are leading most of that. We were able to make some really huge substantive changes, but they didn't meet any of their metrics that year. It didn't, that all of the work that we did was more foundational than that. It was getting them to a place where they were ready to approach things like hypertension control and tobacco cessation. Since then, they've made huge strides in their metrics. But for that one period, we were much more focused on the structure and the relationships within the clinic, and that's where my effort went.
Do you
want me to give another applied example? Because I'm happy to.
Joel, you were also itching to grab the mic.
Just a quick note, not an example. I want to draw a parallel between enabling patients to be able to address clinical goals and what we have to do before we get there. A mother who's, I remember a case, how home is in disarray and could not work on smoking cessation, could not work on anything before that was addressed. It's remarkably similar. We should learn a lot about these relationships we are familiar with in medical care and healthcare, rather primary healthcare, and apply these to these settings.
I'll just give a quick one, and I think it gets back to the value piece, an interesting perspective on the value. So I was working on a tobacco cessation project. I was in Eastern Oregon. And as I'm sitting with the team, they said, actually today we'd like to talk about hypertension. We were just at a training that Stephen and our colleagues gave a different part of the state, but they had attended, and one of the MAs in the room had realized at this hypertension day-long training that reviewed the metric and workflows and QI in general, she had been blown away by what was behind the metric, the importance of blood pressure, some of the why behind why we're doing this work and why it's important to evaluate. And she said, I would like to, as a first step, give some of that presentation to my MAs, my colleagues, so we're all aware of why this is important. And I think reorienting on the why and can really increase the buy-in. The MA was really emboldened to lead that. And then they, from that discussion, started coming up with, let's hang markers for an initially elevated blood pressure so we can take a second one, and had these ideas I'd seen elsewhere that they were creating from their discussions. So I like the reorienting on the why when we get embedded in our metric fatigue and you look what's behind it and the patients and the processes. So.
Thanks. One of the questions we had for you, and we're getting a little tight on time, so I'm going to ask you to talk speedily with your neighbor. But you've heard a little bit about what facilitation is, right? So it's an ongoing relationship to help practices make and achieve transformational goals. And those sometimes might be goals that are coming from a funded initiative, or as you've heard in the examples, you might be sneaking in either building initial capacity or other topic areas because you're trying to meet the practice where they're at. What I want you to do is just talk with your neighbor, and this conference is really about, keeping prevention on the table in light of disease outcome measures. And I'm wondering, for facilitation, what are some outcome measures that are important to you? What would you want to see us evaluating as we're looking at the role of facilitation in helping practices? So talk with your neighbors for 2 minutes. So outcomes. We're really interested in hearing what you have to say. Did anybody have some outcomes that they wanted to share? Let's just popcorn around the room.
We talked about level of engagement as an outcome.
Yeah.
That I don't know if there's a scale for it. We sort of were popping around ideas here, but if you don't have a high level of engagement, then you can't get to anything else.
And I think for many outcomes, they should be longitudinal, because I think there's a really interesting trajectory, even in facilitation, of how you, and that's, I think, part of why people are tailoring what they're working on the clinic with. What's another outcome that might be of interest or important? Yeah, we have a...
Hey, Paulette from VCU Family Medicine.
Thank you.
I kind of span the border of being a research assistant solely, but I'm a wannabe practice facilitator, as I've told Crystal and the team. But my thing for me is being the face of a project, for multiple projects, whatever's on the table with my PIs. But when I show up to the practice, they don't see me as a burden, that they really see me as a partner. And I realize I have varying practices, back to Dawn's point, of engagement. We have some practices, oh, Paulette, I know you have something cool for us to share, because those are my high flyers. They love research. Anything you ask them to do, they'll pretty much do it. But then you have practices who are just baby steps into doing this work and participating in PBRN activities. And how do you slowly build that relationship so they really welcome you and open the door and, to support them. Yeah. So
that's a beautiful example, yeah. And I think illustrative, too, of, again, facilitators running the gamut of how they are engaging practices over time. Stephen's going to Greg. Go ahead.
We talked about kind of two outcomes. One short-term, kind of like what Don said, engagement, even said satisfaction, that practices are satisfied. But as you talked about the longitudinal part, and my new friend, talked about long-term funding. Funders don't care about satisfaction and trust and things like that. How do we translate, does satisfaction and trust and engagement translate into outcomes? And so longitudinally, are practices that are engaged with facilitators better at QI, and then does that translate into better outcomes? And so that's the long-term kind of outcome we need to find.
Yeah, and I think that's, being mindful of time, kind of a beautiful place to transition to final words of wisdom. And I think this longitudinal outcomes also gets to, it's Shanti, your question about opportunities for facilitation. I think this is one of the challenges, right, in terms of how facilitation has traditionally been funded, which tends to be project specific, short of some early work that ARC did to help build PBRN capacity. I think it also raises some questions. There's a growing body of evidence about the effectiveness of facilitation, and so as that evidence grows, there are investigators who want to use facilitation as an implementation strategy for getting a specific intervention into practice. And so I think part of what we've tried to illustrate some in our panel is this importance of longitudinal relationships and meeting the practice where they're at, similar to community-based participatory research or other participatory research approaches. Because when we're thinking about facilitation, as Jolt mentioned at the start, relationships longitudinal over time, it's really critical that we have fidelity to the model, which is not just about what intervention or what outcome are we trying to get to, but really how do we build that capacity and how do we look at kind of that growth and development over time. So in the interest of getting people out and letting Dawn come in, I want to ask our panel to offer any kind of words of advice or words of wisdom, either to folks who are working as a facilitator or considering working with a facilitator, either as a researcher or a clinician.
All right, I have just a few words. Three things. One, to the issue of, am I a research assistant? Am I a practice facilitator? Recognize the value of the skills and assets that both of those positions require and work to, in the context of a PBRN at least, to blend those. That's the approach we've taken, to really blur the lines between those two. Recognize what your practice facilitator can bring to the table when you are developing programs and projects, and be authentic. We've talked yesterday about there's not this checklist of things that you do and then you're a practice facilitator. You need to do it in a way that's authentic and genuine to yourself.
I really quickly just want to address the point that Greg made about the longitudinal, sort of the funding stream for how do we get this to continue. And I think that makes a lot of sense. That conversation is definitely something we talk about all the time. Definitely an important thing to keep in mind. But from my perspective as a facilitator, who is not necessarily the one writing all of the grants that we're trying to get, as the body of evidence around why facilitation works grows, I think that conversation needs to shift away from how can we prove that facilitation leads to better outcomes, and to be more of a conversation around facilitation as a tool that we have chosen to use in the work that we do. And so just in the same way that we need copiers and computers and paper and printers and all of that kind of stuff, this is our model. It's been proven to work. We've chosen this is how we're going to accomplish the goals of the grant. And so I think it needs to be looked at as less of a line item for a budget for a specific project and more of an implementation strategy that's a little more universal than we have been looking at it.
And I'll just jump in here. We didn't necessarily get to how facilitators work with QIs or in larger systems, but there are, for example, you might have internal, external facilitators. So I think what Stephen is also mentioning is there are some hints of this getting built into payer organizations or larger health systems. And so, there's a real opportunity to think about what's the hierarchy and how do you build the structure appropriately, given the fact that clinics might be affiliating with larger institutional systems. But I think there's still a role for facilitation there, because you can come as an outsider and maybe sometimes surface things that people on the inside don't feel comfortable bringing to the table. So.
I guess I'll close. Melinda keeps saying meet the practice where they're at, and I think for facilitators, advice would be to learn some of the motivational interviewing tenets. I think they apply well to practices with being supportive and motivating change without telling them what to do. So if I've seen as practices come up with their own ideas, they implement them a lot more than if I tell them, hey, do this. Similarly with patients, I've heard. So I would say those tenets are well applied to practices as they are with patients.
I would like to speak briefly to those of you who are starting practice facilitation or thinking about. I strongly encourage you to seek out one of the training programs that are nationally available right now. And we can give you more information about these. There are several of these programs nationally. They are quite good and can help you start your work. The second is for you, those of you who don't know primary care well, I recommend that you get to know primary care and get to love primary care. That enthusiasm, that fire that we feel for improving primary care is contagious, is able to carry you through a lot of things. And then the third is to seek out the help of experienced facilitators. The national training programs have shadowing components, but locally in your area, and peer-to-peer learning. We are working on learning communities for practice facilitators, just as for PBRNs. Maybe one day we'll have an organization for practice facilitators. So these infrastructural supports are so important for all of us who are trying to either start or promote practice facilitation.
So I want to thank you all for hanging in with us the last segment of the day. We blame Dawn for doing that. I wanted to just reiterate, we really had those 3+1 goals. We wanted to highlight what facilitators do. We wanted to share some of the ways the profession is evolving and to think about ways that you could engage with the profession or participate in the profession, and then draw those parallels between patient and clinician care. I think all of us really have a strong attachment. You know, you get pet practices and you think about them even if you're not working with them, and you really want to see them thrive. And so I hope there are opportunities in the future both to study facilitation but also to keep to the roots in terms of ongoing longitudinal kind of practice-centered relationships over time. So thank you so much to our panel, and thanks for the opportunity. We hope to see you all tomorrow.